In this capture, we're going to talk about diabetes, or as Wilford Brimley would say, diabetes. So, in order to really talk about diabetes, you first need to understand normal endocrine pancreatic function. Okay, remember the pancreas has both endocrine function and exocrine function. So, when we were talking about the pancreas in relation to the gallbladder and gallbladder disease, we were talking about amylase and lipase. Those are exocrine functions. Now we're focusing on the endocrine piece. So when you think about endocrine function, the first thing we think about is insulin. And insulin is produced in the pancreas, in the beta cells, and the islets of Langerhans. Okay? That insulin that's produced is what's going to take glucose from the blood and move it into muscle, liver, and fat tissue cells. Okay? It's kind of like a lock and key mechanism. The insulin is literally going to take the glucose in there. The glucose can't get in on its own. So kind of think about the glucose as a child who got off the school bus. Okay? And mom takes them by the hand. Mom's the insulin. Mom takes them by the hand and they go into the house, into the tissue, into the cell. Okay? Insulin needs to be there in order for glucose to get into the cell. Glucose cannot get in there by itself. You also need to understand glucagon, which is a hormone that's released by the pancreas that will cause the liver to break down stored glycogen. Okay? And it will do that in response to dropping blood sugar levels. So if you think about you sleeping at nighttime, unless you get up and raid the refrigerator every 2 hours, 3, 4 hours, okay, you're not eating anything throughout the night. So what keeps you from bottoming out with your blood sugar is this glucagon that tells the liver, hey, we need some glucose, so break down some of that stored glycogen that you have. The other hormone you want to think about is amylin, and this is a hormone that's going to delay the absorption of digested glucose into the bloodstream. So this is really important with managing the glucose levels in the blood. You need to understand that the glucose that's not immediately used as we take it in is going to be stored by the liver as that glycogen. And as I mentioned before, when those glucose levels fall, that glycogen is going to be broken down to be released and used as glucose. If you learn nothing else, understand that glucose is the main source of your body fuel. Okay, the only energy that your body cells can use is ATP. The easiest way to make ATP is with glucose and oxygen. Okay, so you need both. So again, in order for the glucose to get inside the cells, you need insulin. You need insulin to help it along the way. So what your pancreas does is continuously, 24/7, it releases a small amount of insulin. This is what we call our basal insulin. Okay, so round the clock, it's just giving me a little bit of insulin. Then when it becomes mealtime, and your body knows because you smell food, you put that first bite in your mouth, when it knows that you're eating, it's going to say, oh, hey, pancreas, we need some extra insulin. And it's going to kick out some additional insulin to deal with the carbohydrate load that you're ingesting. Okay, so kind of think about that as bolus insulin. So that's how everything works there. You also need to understand how your body naturally responds to raises in the blood sugar. Because the reality is when you eat food, okay, it's going to cause a rise in your blood sugar. Okay, the key is in healthy people, the rise is not too significant and it comes back down fairly quickly to a baseline level. Okay, but when your body is inundated with glucose, okay, maybe you ate a huge piece of chocolate cake, okay, your plasma, so when you eat it and it goes down the esophagus, gets into the stomach, gets into the small intestine, and that glucose gets absorbed, your plasma, your serum becomes very concentrated with glucose. Because it's so concentrated, your body doesn't like that. Okay, so it's going to stimulate you to drink. Okay, who can have a piece of cake without a glass of milk? Anyway, it wants you to drink because it wants to dilute out that concentrated glucose. So that's the first thing that's going to happen. You're going to get thirsty. Your body's going to stimulate you to drink. The other thing that happens is the kidneys recognize that there is too much glucose in there. So what it does is circulates that through and it starts excreting glucose in your urine, trying to get rid of that excess glucose. Okay? That is how the body naturally responds. So when we talk about pathophysiology of actual diabetes, okay, in type 1 diabetes, there is a total lack of insulin. The pancreas does not produce insulin whatsoever, okay? So this patient can be eating. None of that glucose is going to get to the cells, okay? These patients absolutely need external insulin injections, an insulin pump in order to survive. Okay, so that's type 1. There is no insulin whatsoever. With type 2, it's a little bit different. Okay, the pancreas doesn't release the insulin properly. The insulin that it makes is not effective, or the body prematurely destroys the insulin that is produced. The insulin that's produced is kind of defective in the sense that the body tissue doesn't accept it. So there's a lot of different things going on with type 2 diabetes, but the big difference is with type 2, the pancreas is still making insulin. Okay? Now, that being said, a person with type 2 diabetes, depending on how long they live, eventually they will get to the point that they will require some insulin supplementation. Okay? But with type 2, the body is still making some insulin. We're going to focus the majority of this capture and our time in class on type 2 diabetes. The VSIM that you'll do as part of this unit focuses on type 1. Okay? But a lot of the patients that you're seeing is going to be related to type 2 simply because America is getting fatter, we're getting older, we're seeing more type 2 diabetes, not only in adults, but also in young adults, adolescents, and even young children. Other types of diabetes, gestational diabetes, so that is glucose impairment associated with pregnancy. A lot of the same principles of regular diabetes do apply, and you will talk more about that when you get to your OB class. There's also, your textbook talks about diabetes mellitus associated with other conditions or syndromes. Years ago, we used to call this secondary diabetes. So basically, this is just the incidence of hyperglycemia associated with either a disease or a medication. And the best example of this is patients that are being treated with IV or PO corticosteroids for some inflammatory process. Our COPD exacerbation patients who are treated with IV Solu-Medrol when they first come into the hospital, their sugar is going to shoot sky high, whether they're diabetic or not. Okay? It has nothing to do with what they're eating. It is a side effect of the medication. The other classification that your book talks about is pre-diabetes. And these are people that don't meet the diagnostic criteria for diabetes, but their body is definitely showing some signs of impaired glucose metabolism. If you can catch them in the pre-diabetic phase, and we can start making some lifestyle changes and maybe even put them on metformin, we can potentially kind of reverse or at least delay what is happening. So that's pretty important. As the disease progresses, it is going to cause damage systemically to the body. We talk about macrovascular damage, microvascular damage, and then we talk about neuropathic. So let's examine that a little bit more. Macrovascular damage is what is going to increase the cardiovascular risk for these patients. So basically what happens is the normal age-related changes related to atherosclerosis, this is all accelerated. So the arteries are going to become stiffer more quickly. They're going to have buildup of plaque on the vessel walls. That's going to cause narrowing. What all this basically means is they're going to be at risk for an ischemic event, either with coronary artery disease, an MI, heart attack, a TIA or CVA, which relates to a stroke or a mini stroke, or PVD, which is peripheral vascular disease. From a microvascular standpoint, the high glucose levels actually damage the capillaries and the microvessels in the eyes, in the nerves, and in the kidneys. Okay, so retinopathy, diabetic retinopathy, eventually results in blindness, blind spots, and then progressive to blindness. Nephropathy, it actually damages the nephrons in the kidney. They will lose their ability to filter, to concentrate and dilute urine, eventually to even make urine. Okay? It causes damage to the nerves, peripheral and autonomic nerves, and this causes increased pain impulses. It causes paresthesias, numbness, and tingling. And when it's affecting the autonomic nervous system, it can actually result in what we call hypoglycemic unawareness. So when these patients' blood sugar drops, they don't have the classic signs and symptoms of hypoglycemia, which can be deadly for your patient because they literally can go from talking to you and have their sugar drop and be completely unconscious. With the neuropathic issue as well, patients can develop numbness or inability to feel sensation, particularly in the extremities, and we tend to think about the feet. This can be a problem because if they develop a sore, they develop a cut, an infection, it can really, really fester and advance very quickly before the patient even becomes aware of it. So diabetes is a big deal. So what are you going to see in these patients? Expected findings. We have some terms here. Polydipsia and polyuria. These relate to exactly the body's normal response to hyperglycemia. Polydipsia is increased thirst, increased fluid intake. Polyuria is excessive urination. Okay, it's just part of the body's typical glucose management. We want to dilute the serum concentration, increase renal excretion. The other poly, you'll hear us call them the polys, polydipsia, polyuria, and polyphagia. So polyphagia is excessive hunger, excessive food intake. So this actually occurs because the cells are literally starving. They're starving in the sense that the glucose is not able to get inside the cell for the cell to make ATP. Okay, so polyphagia, you're going to see mostly more pronounced in type 1 diabetics because literally their cells are starving. Remember, in type 1, that pancreas is not making any insulin whatsoever. So all the glucose that your patient's taking in, it can't even get into the cell to be used. Okay, your cell has now switched to anaerobic metabolism. It starts breaking down fat instead of using glucose as its main source. It's a really big problem. This is why your type 1 diabetics, particularly before they're diagnosed, are rapidly losing weight. They're eating and eating and eating, but none of that glucose is actually getting into the cell. With type 2 diabetes, the polyphagia really isn't noticeable, and those patients tend to be overweight to begin with, so it may not be completely unexpected. Type 1, as I mentioned, generally has a very acute, rapid onset, whereas type 2 develops very slowly over the years. It is very insidious, which is why patients really need to have annual checkups. Part of that needs to be blood work so we can identify trends of glucose impairment before we even get to this point. Other expected findings include generalized fatigue and weakness, tingling or numbness in the hands or feet, dry skin. Diabetic skin is just so dry, particularly in the wintertime. You might notice skin lesions or wounds that are very slow to heal. maybe some vision changes. And the other thing we see a lot is recurrent infections. And particularly in women, we see it as UTIs and vaginal infections. And it's just simply because there's more glucose in the body. Glucose is a perfect breeding ground for bacteria and other pathogens. It's a perfect food. From a diagnostic perspective, there's several laboratory tests that can identify and diagnose the presence of diabetes. The first is your fasting plasma glucose. We consider results at or above 126 milligrams per deciliter on 2 separate occasions. We consider that to be diagnostic for diabetes. Now, fasting means that they have been NPO for at least 8 hours. Okay, at least 8 hours, nothing but water. Okay, now, a true fasting glucose, the normal is 70 to 100. So that kind of leaves that area of 100 to 125. Results in that range are considered pre-diabetes. Okay, again, they don't meet the diagnostic criteria completely, but the patient is definitely showing signs of some glucose impairment. Another diagnostic test we'd look at is just the casual plasma glucose. They can draw blood at any given time. If it's above 200 milligrams per deciliter, plus the patient is having signs and symptoms of diabetes, that is considered diagnostic. They can also do glucose tolerance tests, and basically they draw a baseline. They have the patient drink a load of carbs. It's like a drink that they have to drink, and then they will test their glucose at certain intervals. They'll draw blood and test it at intervals after drinking it. You can have a 1 hour, a 2 hour, a 3 hour glucose tolerance test. We don't typically see those used as much in the diagnosis of regular diabetes, but the 1 hour glucose tolerance test is used as a screening tool for pregnant women looking for gestational diabetes. And if that is showing abnormal, they usually progress to a 3 hour glucose tolerance test. Okay. The one I really want to emphasize here is the glycosated hemoglobin, or the glycohemoglobin, the hemoglobin A1C. Okay, this ties back to Unit 3 in the sense that it is looking at the amount of glucose saturation on the hemoglobin molecule. So if you remember back from Unit 3, red blood cells, average lifespan is 90 to 120 days. So when we look at a hemoglobin A1C, it basically tells us the average glucose level over the previous 3 to 4 months. Okay, so it's a really good indicator of long-term glucose control, and it's very helpful for diabetic patients to evaluate is the medication regimen, is the diet regimen, insulin, whatever, is it working? Is it effective? So a normal A1C, depending on what reference you're looking at, but typically you're looking at 4.5 to about 5.9. Sometimes I've seen the size 6.3, 6.5. Our goal for diabetics is for them to be below 7. That is our goal. The research supports that the lower the A1C level is, the longer it's going to take for this patient to develop the complications related to diabetes. And that is critical. Other things that would be useful, a lipid profile. Many times patients with diabetes also have hyperlipidemia, and they also have hypertension. So looking at the lipid profile, their total cholesterol, their LDL, their HDL, their triglycerides. Certainly looking at kidney function, particularly thinking about the disease sequela with the nephropathy. So monitoring BUN, creatinine, and GFR. A urinalysis, looking for the presence of glucose. Do keep in mind that for glucose to be present in the urine, typically the serum blood sugar is about 180 when glucose starts spilling into the urine. We also look at a test, it's a urine test, it's called urine microalbumin. And this is a really good indicator that they typically do yearly to help evaluate kidney function as well. How well are the actual nephrons filtering. Again, as I mentioned before, the goal is to normalize the blood glucose levels. We want to keep their A1C below 7. We know that the research supports intensive control is going to decrease the severity and it's going to delay the onset of those complications that I was talking about, the macrovascular, the microvascular, and the neuropathic complications. So let's switch gears and talk about the different prongs of treatment. And we'll talk a little bit more in class, but some key principles of dietary management for your diabetics. I don't care what type of carbohydrate it is, if it's a simple carb, if it's a complex carb, if it's a whole grain, if it's refined white sugar. Once it's digested, 100% of carbohydrates are converted into glucose. The difference is how long does it take to digest them? A simple sugar versus something that's complex versus something with fiber. Okay? So, that being said, for type 2 diabetes, overall, the focus is going to be reducing calories, eating a low-fat, low-cholesterol diet, and really aiming at losing some of that weight. Okay? We know that if a patient is able to lose 10% of their weight, okay, 10% of their weight, it dramatically improves glucose control. The body cells start being more receptive to the insulin. The pancreas starts producing more effective insulin. So weight loss is huge. And we'll get that way through exercise and also through dietary management. The other thing that's going to be important is spacing calorie and carb intake throughout the day. Okay? If you kind of think about, you don't want huge peaks and then valleys. Okay, so you want to space your carbs throughout the day. That's what we call a consistent carb diet. Okay, if I go for a pancake breakfast, if I eat lots of pancakes, my sugar's going to be sky high. Okay, I don't want to be sky high. I want to space my carbs throughout the day. Now, your book talks about various food classification systems, and we'll focus on this a little bit more in class. But the one principle that I want you to really understand is when we're looking at food labels, and you need to know how to read food labels. That was a foundational concept. So if you're not familiar with that, you want to go back into your ATI nutrition book and review that. But on the food label, 15 grams of a carbohydrate is going to equal 1 carb exchange. That is a really important key point to know. Generally, we tell patients they want to have 2 to 3 carb exchanges per meal. And they want to balance those carbs with protein and fat. If all someone is eating is carbohydrate, that's going to get burned up by the body fairly quickly. Adding in protein and adding in fat will also allow the patient to feel fuller for longer, and they won't be snacking in between as much. So some key points for exercise management. I mentioned before, type 2, weight loss of 10% is going to improve the body's ability to use their insulin. Okay? So for a 200-pound person, we're talking 20 pounds. It doesn't have to be overnight. It can be steady over several months, but we're trying to achieve that weight loss. So in doing so, consistency is the key. Anytime somebody tries to make a major lifestyle change, okay, and they just go all in without any breaks, it's like trying to quit smoking. It's very difficult to do. So with exercise, consistency is going to be the key. Start slow and go. Even if it's taking a walk, a 10-minute walk 3 times a day. Maybe parking a little bit farther out in the parking lot at the grocery store and walking a little bit farther in. Whether it's taking the stairs at work instead of the elevator. Every little bit counts. You have to consider the patient's lifestyle. Do they already have some cardiac disease? Do they already have concurrent lung disease? That might limit what they're able to do. Okay? Do they have diabetic neuropathy and they already have foot problems and that? Again, might limit what they're able to do. So we want to work this into their lifestyle. But even something as simple as walking 10 minutes 3 times a day, every day, is going to make a difference. For type 1 diabetics in particular, you want to be very careful about hypoglycemic episodes with exercise. So they should check their levels before, during, and after exercise. Okay, just to make sure they're not going to drop. If the patient takes insulin, they should have a carb exchange, something equivalent to a carb exchange before they start exercising, just to make sure they're not going to drop too low. And it is good practice for all diabetics to always carry some sort of fast-acting simple sugar and a carb protein snack to prevent or treat hypoglycemia that might occur post-exercise. Okay, so that's a safety piece. Blood glucose monitoring is also an important cornerstone of diabetic management. It gives immediate feedback. It can tell us if the patient's hyperglycemic, hypoglycemic. It just gives us some immediate data that we can respond to. Patients who are taking insulin should be testing multiple times a day. Patient on oral medications, they're generally told to test up to 4 times a day. A lot of times they might test once or twice a day, but you can still get data throughout the day if you have them rotate their testing times on a daily basis. So maybe today I'm testing before breakfast, tomorrow I'm testing before lunch, the next day before dinner, and the following day at bedtime, and just kind of repeat that cycle. By the time they go to see their doctor, they'll have several readings for each time frame, and the doc will be able to take a look at the averages of where they're at throughout the day. Patients should be taught to track their results, whether it's on paper or it's one of the many apps that exist out there for diabetic patients. They should be testing more often during regimen changes, if we've changed meds, if we've changed insulin. If somebody is ill, okay, because during periods of illness, your patient is actually at very high risk for hyperglycemia. And it can get very high, and we can get into complications like DKA and HHNKS, which can be life-threatening. So if they're ill, and particularly if they're on insulin, they need to be testing every 3 to 4 hours. If they're on insulin, they should be testing before and after exercise. Speaking of insulin, nowadays our insulin is human insulin. It's genetically engineered. And for the most part, we're going to be using U100 insulin. So if you look at the insulin vial, it'll actually say U100, which basically just means there are 100 units per milliliter of insulin in the vial. Okay. Years ago, we used to have different concentrations of insulin. So you needed to make sure you looked at the insulin concentration, and you also needed to look at your syringe and what it was calibrated for. Pretty much everything that you're going to see now is going to be U100 insulin. And just to minimize errors, if you have a patient that has extremely high insulin needs, that they would require something like U500 insulin, typically in an acute care setting, pharmacy is actually going to prepare the syringe for you and label the syringe for you when you're getting on those odd things like that. With insulin, you want to understand that there are different types. And when I mean different types, I'm talking different onset, peak, and duration of these types. So you have rapid acting, short acting, intermediate acting, and long acting. Hospitalized patients and even patients at home that are on a regimen are often on both long acting, and in the hospital they may be on rapid acting insulin as well. Rapid acting insulin is typically what we use for sliding scale coverage on the acute care unit. Things to keep in mind: that insulin has to have carbohydrates to work on. Okay, the highest risk for hypoglycemia is when the insulin type is peaking. So it's important that you understand the onset, peak, and duration of the different types of insulin. You need to consider if your patient is NPO. Okay, a lot of times we might still give sliding scale coverage if they're NPO, but we're certainly not going to give the intermediate and the longer acting insulin if they're NPO. If they have a decreased appetite or oral intake, that can affect them, especially if they have their full scheduled dose. We need to be careful they don't drop farther along in the day. If they're having nausea and vomiting, they're just not taking in. Again, you want to consider those things. Insulin is available as a vial or a syringe. With those together, it's available as a pen. Some patients use continuous insulin pumps. Okay, so there's a lot of different forms of this. As a nurse, you need to be familiar with all of them. Oral anti-diabetic agents, these are used for type 2 diabetes. These are not used for type 1. And that's really critical that you understand that. Oral anti-diabetic agents are going to work in one or more of 5 different ways. And we'll talk more about this in class. But it is not uncommon for a diabetic patient to be on multiple medications that work in different ways. Okay, so you want to understand how they work. First, some of them will stimulate the pancreas to produce more insulin. Others will increase tissue sensitivity to insulin. So we're trying to reduce that cellular resistance. Some of them will slow down carbohydrate digestion and absorption. Some of them inhibit glucose production by the liver. Okay, so it won't allow the glucose to be stored as glycogen, or it won't break down glycogen as much. And the other way that these work is by promoting the kidneys, causing them to excrete additional glucose. Okay, so your oral anti-diabetic agents are going to work in one or more of those 5 ways. And we will look at specific classifications and how they work in the classroom. So obviously we're talking about a chronic disease that requires lifelong management. So client education is going to be extremely important. When we talk about survival skills, there's a lot your patient needs to learn about diabetes. I'm telling you, when they get their diagnosis, it is going to be overwhelming. It's just going to be, there will be a point where they're looking at their life. This was my life before I had diabetes and afterwards. It truly can hit them like a ton of bricks. I know it did for me. I mean, it wasn't a surprise. I don't miss very many meals. I have a family history of diabetes. I had gestational diabetes. But that day when I got the diagnosis that, yes, this is no longer you are diabetic, it hit me like a ton of bricks. I started on medication, immediately. But I didn't tell my family. I didn't tell my husband. I mean, obviously, he's not a fool. He saw the medication bottle. He can look up what it is, so he knew. But I didn't actually come out and tell him. I couldn't actually tell those words to him or even my mother for several months, that it really took me that time to really come to terms with the fact that, yes, I am diabetic. Now I have no problem talking about it, but it was a lot then. It really was. So getting back to client ed, you need to make sure they know the critical information. They need to have a basic understanding of simple pathophys. If it's type 1, their pancreas doesn't make insulin. If it's type 2, their pancreas doesn't make or use insulin properly. Their cells don't use the insulin properly. Okay? They need to know the basics. They need to know the treatment modalities that are going to apply to their specific treatment. What medications are they going to be started on, and the key pieces on those meds. If they're being started on insulin, what type of insulin is it? How does it work? How do I give it? They need to know the basics about meal planning. Okay, that 15 grams of carbs equals 1 carb exchange. They need to know the basics about exercise and, of course, blood glucose monitoring. That's going to be very important, especially at first when they're learning how their body is adjusting to this new regimen, new medications, new insulin. They need to know how to recognize, treat, and prevent acute complications. And we'll talk a little bit more about those, but the most common one we worry about is hypoglycemia. How do they prevent their sugar from dropping extremely low? How do they recognize it? How do they treat it? What do they do if it happens? Same thing on the flip side for the hyperglycemia. When we get into the severe complications, the diabetic ketoacidosis, the hyperglycemic hyperosmolar non-ketotic syndrome. Those can be life-threatening. So they need to know what they are, how to prevent them. We're going to talk about a sick day plan and how to work with that to try to prevent those things. They need to know practical information like, where do I get my lancets? Where can I get a meter? How do I dispose of my used lancets or used needles? When should I contact the doctor? What is a phone call to the doctor versus what is I need immediate medical attention at the ER? The biggest thing you also want to emphasize is the need for follow-up care. Diabetes is a lifelong chronic illness. This is not going away. Okay, so it's very important that they establish a strong relationship with their provider and really the interdisciplinary team, because they might be seeing a pharmacist for medication management. They might be seeing a dietitian. In some cases, they might be seeing an endocrinologist. So really establishing those relationships. As they develop complications, they might be seeing a kidney doc. They should be going for eye exams, so they should be linked up for an ophthalmologist. They should be linked up with a podiatrist. So it really is an interdisciplinary team. And you want to emphasize to them that controlling their glucose level now, that is critical to prevent and manage long-term complications. So looking at hypoglycemia, by definition, it's an abnormally low blood glucose level, less than 70. Tends to have a very abrupt onset, and your signs and symptoms, they are classic. They might be sweating, very diaphoretic. We always call them cold and clammy. Years ago, we used to say cold and clammy, give them some candy because their sugar's low, we need to get it up. They might have tremors. Their heart rate's going to go up. They'll be tachycardic. They might feel palpitations. They might have a headache, be very irritable. You can see some confusion, altered level of consciousness, slurred speech. Sometimes, to be honest with you, they look like they're drunk. I have seen law enforcement officers mistake hypoglycemic episodes for drunkenness. Okay, so it can look like that. The one thing you really want to keep in mind is that people that have been diabetic for a long time and have some nervous system damage, particularly to the autonomic nervous system, or if they are on beta blocker therapy, they may not have those classic signs and symptoms of hypoglycemia. They literally can be talking to you and be unconscious the next minute when their sugar drops. It's called hypoglycemic unawareness. So that's something that's really important for you to know. So what do? If you suspect hypoglycemia, your first step is going to be to check the glucose ASAP. Now, that's perfect. If you're in the hospital, you have the means to check the glucose, and then you can respond from there. If you're out in the field, you have no way to check their glucose, assume that it is hypoglycemia and treat it. Even if it's not, let's say it's something else and their glucose level wasn't low, okay, you're going to cause their sugar to go up temporarily, it'll come back down. All right, but if their blood sugar is too low, when we start getting below a blood sugar of 30, that is depriving the brain of the nutrients that it absolutely needs, and that could be life-threatening. Okay, we want to deal with it before it gets to 30, but when we get below 30, that's really causing damage. So what's going to kill your patient first? Low blood sugar or high blood sugar? It's going to be the low blood sugar. So you want to give 15 grams of fast-acting concentrated carbohydrate. If they are conscious and they're able to swallow, you could give them 4 ounces of juice or regular soda. Okay? You can use 3 to 4 commercial glucose tablets, 6 to 10 lifesavers or hard candy. You want to give them a carb load that's equivalent to 1 carb exchange. If they are unconscious, or they're conscious and not able to swallow, or they're kind of conscious going in and out, but no way am I going to have them drink anything, you're going to use IV dextrose or IM glucagon to get that sugar up. You want to recheck the glucose level in 15 minutes and retreat them again if they're still below 70. If it's going to be more than an hour to their meal, they need a snack with both protein and carbohydrates. The carbs will get their sugar up to where it needs to be now, and the protein will slowly keep it up there for a period of time until they can have an actual meal. Diabetic ketoacidosis and HHNKS. I'm only going to talk about these for a couple minutes. These are higher level concepts that you're going to talk about in Med-Surg 2. This often occurs because somebody is either not following the treatment plan or they have an acute illness that has caused their sugar to spike significantly. Okay, this is why your patient needs a sick day plan. When you are ill, your body naturally uses more energy. Your metabolic needs are higher. So even if you're sick, you're not eating, you're not drinking, your body, your liver is still breaking down glycogen to provide that glucose source. That's what causes the sugar to go up. Okay, so this is why it's very important for diabetics to check their blood sugar frequently when they're sick, especially if they are on insulin. Even if they're not on insulin, but especially if they're on insulin. Okay, they're going to treat themselves, people on insulin, based on those results. So typically we actually will still have those patients take their insulin to keep their sugar from becoming too high. If they get to the point where we're talking diabetic ketoacidosis or HHNKS, we're talking glucose levels above 600, 700. The highest that I ever saw was in like the 1300s. Okay, and that was with HHNKS. So what happens with this is you have an extremely high glucose level. The patient becomes dehydrated because the kidneys are trying to get rid of this extra glucose, and it alters their level of consciousness so they can literally not be able to take in fluids either. So it is an extremely hyperglycemic state along with a severe dehydration. Now, this is where they kind of digress a little bit because diabetic ketoacidosis also involves a acute severe metabolic acidosis with it. Okay? DKA you tend to see more in type 1 diabetics. HHNKS you're going to see more in type 2 diabetics. What you need to understand is this is serious, this is life-threatening, and we're going to treat them with IV fluids to correct the massive dehydration. We are going to treat them with an insulin drip, IV insulin, to get the glucose moved back into the cells, okay, to bring their glucose levels down. Now, we need to do that slowly. We don't want them going from 1200 to 800 in 1 hour, okay, because that's going to shock the body too. So very close monitoring of the glucose levels, very close monitoring of the potassium, because in addition to insulin taking the glucose inside the cell, it will also take potassium in there as well. So we want to be very careful that we don't drop their potassium too low. In some cases, these patients may require IV bicarbonate to try to correct the acid-base imbalance. So looking at prevention and management of your longer-term complications, the stuff that I was talking about before, the disease sequelae, your macrovascular, your microvascular, and your neuropathic. These patients should be seeing their provider at a minimum twice a year, where they should be having blood work. A1C, a metabolic panel, lipid panel, they should have a urine for microalbumin, and they should have a foot exam or at least a screening, looking for any breaks in the skin, assessing their sensation, asking about any numbness, tingling, paresthesias. They should have a yearly eye exam with an ophthalmologist. Depending on what that eye exam shows, when they start having the diabetic retinopathy, there's treatments related to photocoagulation, cryotherapy, vitrectomy, as needed. These people should avoid nephrotoxic medications, things like NSAIDs. Not that they can't take NSAIDs, but they want to make sure they are very hydrated and they don't want to take high doses and they don't want to take them for long periods of time. They should also have a baseline EKG with periodic follow-ups and additional testing as needed, knowing that diabetes is going to increase their risk for heart attack, stroke, and peripheral vascular disease. Foot care. Teaching your patient about foot care is extremely important. They should be taught daily inspection and care of their skin folds, especially the feet and the nails. They need to be actively looking for redness, irritation, cracking, sores, anything like that. If they can't see the bottom of their feet, they need to get a mirror so they can put it on the floor and look. You need to look between the toes, you need to look between skin folds. You want to wash with mild soap and water and pat dry. A good technique for drying that I've seen used is using a hair dryer on cool setting. It must be on cool setting, but to really help dry those moisture between the toes or between skin folds. They should apply lotion to the feet, to the top, to the bottom, never in between the toes though, never in between the toes. They should be wearing appropriate footwear, okay? Shoes that fit appropriately. They're not too tight, they're not too pointy, putting pressure on areas of the feet. They should be wearing absorbent socks and change their socks frequently, okay? And ideally, they should be light colored socks. And the reason we say that is if they develop a problem and there's drainage or bleeding from an area, they're going to see it on that white sock versus a dark colored sock where they might miss the signs of the drainage. They really should never use heating pads or hot water bottles on their feet. Again, because of the neuropathy, they may not be able to feel that it is too hot and it could actually be damaging the skin. In relation to the nails, they should be trimming their nails straight across, never angling at the edges. And really a nail file versus cutting is preferred, really kind of keeping up with that. If they cannot trim their own toenails, doing that, seeing a podiatrist is appropriate. Medicare actually pays for podiatry visits. I think it's every 9 weeks for nail trimming and just foot care to try to prevent problems. So again, collaborating, we talked about the interdisciplinary team, the dietitian, the endocrinologist, podiatrist, nephrologist, cardiologist, case management. It's going to be very, very important in managing this chronic disease. I want to add special things to think about: hospital care for diabetics, frequent glucose monitoring with sliding scale insulin, or perhaps even an insulin drip might be used to maintain glucose control for surgical patients. We know as part of the SCIP measures to reduce complications in patients that tight glucose control is a key factor in preventing complications and promoting recovery. Okay. The reality is most of the patients that we deal with in the hospital that have diabetes, they may not be there because of their diabetes. They're there for another reason, another primary diagnosis, but their diabetes is certainly impacting the care that you are providing, okay? So your hospitalized patients might have diet alterations. So as a nurse, when you're working with them, you always have the opportunity to teach and reinforce knowledge. So you want to assess their knowledge level. You want to know what they already know so you can correct any misconceptions and you can build on what they know. You also want to promote self-care because at the end of the day, when they go home from the hospital, they're going to have to manage this chronic condition on their own.